Okay. Excuse me. So, any other questions? Because then we're gonna move on to our next material. Oh, just seeing what Cindy is typing. The question that Cindy has, if you guys haven't read it, is should we be including information from other resources for the presentation? Um, as a supplement, perhaps, but it's not completely necessary. The two mandatory, or really the mandatory, is your textbook. If you need extra information about the cancer symptoms, or if you need extra information on the organ functioning or the tumor itself, if you find that the textbook isn't enough. But usually the textbook is enough. If you put pictures, you should document or cite where you found your pictures. So it doesn't have to be like you have to have a certain amount of presentations. You just have to have enough information to answer what is expected for the slides. And remember, the outline of the slides for that presentation is specifically listed in the syllabus. So the SEER data does give you information about morbidity and mortality associated with your cancer, and that's a primary source of information. The NCCN, you can look at that and see. The National Cancer Comprehensive Cancer Network, which is what NCCN is, does give you a lot of information about the cancer itself, how the cancer is staged, what are some clinical manifestations, as well as when you're trying to work up the cancer, diagnostics, and treatment. So I used to make everybody sign up for an NCCN account and ask them to look there for staging information, but I think sometimes that information can get distracting from the point of our presentation, because you can certainly make a presentation about all kinds of things regarding your cancer. But since our focus is linking the pathology to clinical manifestations, I don't want our conversations to be directed towards screening or diagnostic workup or treatment. So you can certainly do that, but you don't have to. Then it says, can we send you our talking notes as well, or do you prefer that we use speaker notes within PowerPoints? However you want to do it, Dawn, is fine. Some people like to have notes on the side. Some people like to have the notes on the bottom. It could be either way. The more you send me, the more I can comment on. So I have had people send me, rough drafts of their presentation, and it contains just slides and some minimal ideas. Some people have sent something that's in further stage of development and with some notes, and then I can make more comments. So it's whatever you can send me. And then the next thing is, do we voice over or give live presentations? So we're going to do it live. I'll make us all presenters on this Skype thing. It doesn't necessarily mean that you have to show your face. You can do just what I'm doing, where you share your screen and talk through your presentation while you're speaking with us, and then we can all listen, and at the end, we could ask questions or whatever. But we'll all do it together that class day so we can all watch. And that way we can give feedback in real time to each other. Any other questions? So I'll keep reminding you about it because I don't want you to forget about it, because the end of the class is kind of loaded. It's sort of backloaded on points You get points for this cancer presentation, self-assessment, and points for the final assessment. And so sometimes that is what helps, if you're on the fence, that you're fine. So I don't want people to forget about the end of the semester stuff. Could you make the exam 3 study guide available now? Sure. Where are you, exam 3 study guide? Well, where did I put it? I have to find what I did with it. It's usually in here. That's the case study. I will look for that. It must be on like a different area in my computer during the break and make it available. I'm sorry I don't have that available right now for you. Okay, so I will definitely put that up earlier. I'll try to do that earlier or right away for the next subsequent classes too. All right, so this time, we talked about the important things we talked about in the first class, of course, was cellular injury, mechanisms of cellular injury, the pathways of reversible and irreversible damage. This last class that we had is often complicated because it's cascades of events occurring at the same time, but it's going to come back a bunch of times because the inflammatory process related to tissue injury will occur everywhere around the body depending on the type of injury we're talking about. So if you felt that you didn't have as good of a handle on it as you wanted to, look at your feedback closely when you get it on the exam and the case studies, because it's definitely going to come back again. I don't want you to be confused about it. This time we're going to talk about really the bone marrow itself and how the bone marrow keeps up with the demands of making the cells that are in our bloodstream. And then we'll talk about disorders of white blood cells, specifically leukemias and lymphomas, disorders of red blood cells, in particular anemias and polycythemias, and then the clotting cascade and disorders of coagulation. So we will start with just talking about the bone marrow and blood cells in general. So the blood itself is made up, this is if we spun it down, a blood sample, a large portion of it is plasma, which is the fluid components. Then we have the second largest being the red blood cells themselves, and then the smallest being a group of white blood cells and platelets that are always present as a just in case. So the plasma is primarily water as well as protein. That protein primarily is albumin, and we've talked about that in terms of maintaining oncotic or protein pressure inside of the blood vessel to prevent the water from continually leaking from the vessel. And now that I see the word oncotic, I just want to remind you of the difference between the term oncotic and osmotic, because I've noticed sometimes that people use those interchangeably. So oncotic is specifically pressure from proteins. Osmotic is pressure from concentration. So osmotic pressure proteins could contribute to that because it would pull water. It just means that water will be pulled into an area of concentration. So, but osmotic pressure besides protein could be determined by blood sugar or other electrolyte concentrations or other particles or solutes that might be in the fluid. So just be careful that you don't use those interchangeably because they are actually different. Other products within the plasma are globulin, which are parts that parts that make up antibodies, like the gamma globulin or alpha beta chains, which are part of the red blood cells, and fibrinogen, which is part of clotting. The formed elements are the cells that are made in the bone marrow. So that's the white blood cells, platelets, and red blood cells. Inside the bone marrow, the special thing about the bone marrow is that the actual beginning cell is pluripotent, meaning it can become several different types of cells, and self-renewing. We kind of talked a little bit about self-renewing cells when I gave that like wicked fast lecture about cancer. But stem cells themselves in our adult bone marrow can become and differentiate into progenitor cells, which could end up becoming red blood cells, all the different types of white blood cells, and platelets. So it starts out as a pluripotent stem cell that has the potential to be all kinds of things, and in response to growth factors based on the needs of the body, there will be differentiation into progenitor or particular cell lines, and then further differentiation, specialization into mature cells that make up the blood. So this is a picture of that. We have our stem cell that is in this case we would be saying is the bone marrow cell that would be sent a message, from either that we're supposed to make more red blood cells, more white blood cells, more platelets, that would then cause the stem cell to differentiate into a progenitor cell, which will give us a particular cell line. But we always keep a copy of the stem cell itself, or once we differentiated, we would never be able to make these cell lines again. So that's one of the important aspects of bone marrow, is that it can become many different types of cells, and it is always able to keep a copy of itself so that we can keep doing this process over and over. So here is the types of cells that come from one pluripotent stem cell. So it could go through this right here is the first differentiation. So we would still leave a pluripotent cell behind, and we have a lymphoid stem cell and a myeloid stem cell. So that's our first differentiation. These lymphoid stem cells can then further differentiate into different types of progenitor cells that are going to make lymphocytes eventually. So we have the lymphocyte that's part of the innate immunity response, that natural killer cell, and then we have the progenitor cells that make the T lymphocytes and the B lymphocyte that eventually becomes the plasma cell that makes the antibody. So this lymphoid stem cell only has the capability to make these three cell lines: natural killer cells, T lymphocytes, and B lymphocytes. The myeloid stem cell can become several other types of cells. So we can further differentiate into what will become our monocyte, which activates and becomes a macrophage. Or we can further differentiate into types of granulocytes, which are first-line white blood cells that are called granulocytes because they have granules inside that get released. Or it could become a megakaryocyte, which becomes platelets, which are just fragments of cells, or a erythrocyte progenitor, which will end up becoming a mature red blood cell. So how we decide or what proportion of these cells are constantly being made ends up being related to needs of the body. And the bone marrow is told this by different colony stimulating factors or growth factors or cytokines. Those are all names for the same thing. It's a protein messenger that's telling the bone marrow to differentiate into particular cell lines in order to make the cells the body needs. So erythropoietin is a type of growth factor that would specifically tell the bone marrow to go down this erythrocyte cell line and make more red blood cells. Thrombopoietin is the simulator for platelets. There are granulocyte colony stimulating factors for some of our more immature innate immunity. White blood cells, tumor necrosis factor, which helps send the message to increase lymphocytes. And tumor necrosis factor is released from mast cells that can help start bringing those cells in, especially natural killer cells. And then the interleukin that's released from activated monocytes, macrophages, and other lymphocytes will help increase the amount of especially B lymphocytes, and interferon is part of increasing the amount of T lymphocytes that help with cytotoxic killing of virus and cancer type cells. So all of these factors help in growing the cell lines that we need. And this is just a cross section of what the bone marrow looks like. All these cells that are continuing to divide and grow that can be released into the sinuses of the bone marrow and then released into the bloodstream. So that's just a quick discussion of what the cells we're talking about, where they come from, and what their stimulators are. And we're going to start talking more in depth about white blood cells, because we did sort of start talking about some of the types of white blood cells last class. And so sometimes it can be good to start this conversation with just reviewing the innate and adaptive immune response. So there's a tissue injury that occurs, and there's the release of arachidonic acid from whatever cells membranes are hurt, which helps us develop the prostaglandins. And there is, the beginnings of the other protein cascades like complementkinin and the coagulation cascade. But one of the biggest influencers of the vascular response of the inflammatory process is mast cells that degranulate. And so when we're talking about the vascular response, we're talking about changes that occur to the blood vessel that lead to the symptoms of the inflammatory response. So what do the mast cells do?
They release histamine.
Correct. So what does that histamine do?
Causes contraction of the endothelial cells.
That does. It's one of the jobs of it, and that contraction will then allow fluid and proteins to come out of the vessel. Histamine does one other thing too, besides contraction of the endothelial cells.
It vasodilates.
Yeah.
Right. So our histamine causes vasodilation, which is why the tissue may look red and feel warm, because we're allowing that heat could dissipate, but we're feeling the heat of the vessel. And then the fluid escaping the vessel contributes to the edema and the early exudate, which is usually more clear in appearance. So that's the vascular phase. The prostaglandins and those other protein cascades are only amping that response, including the pain response as well as vasodilation. So once we've accomplished that, where we've started to open up the pores of the vessels to allow fluid to come through, we end up crossing into the cellular phase of the inflammatory process, which is when we start to call in the white blood cells to this area. So that's why it's given its name. So what is that process? neutrophils comes. Right. So the four processes that occur, which might be what other people are typing, to get the neutrophils there, and then the macrophages come second. But there's four processes that get the neutrophils there. First, it's called margination. That's those endothelial cells release integrin and selectin to pull the white blood cells out of the middle of the circulation to the endothelial cells. Were you going to say something, Dawn?
Oh, sorry. I was just typing, actually. It was that the, transmigration
Yes.
and chemotaxis and phagocytosis?
Yes, that is exactly correct. So then the that was margination when we got the white blood cells to the endothelial cells. Then the neutrophils transmigrate, meaning they leave those pores that were already been opened during the vascular phase. And chemotaxis is them sort of following the breadcrumbs, the path to where the problem is. And phagocytosis occurs when the neutrophils begin to phagocytize or take in foreign material, which could be blood products, it could be platelets, it could be cellular debris, or it could be infectious elements, depending on what the tissue injury has been. And that process of phagocytosis occurs, whatever the neutrophil has taken in will interface with the lysosomes inside. And then neutrophils are not capable of antigen presentation, and they are not capable of division. They will send a message, a growth stimulating factor message to the bone marrow when they're being used to say, I need more. And then they will necrose or open, and their contents become part of the exudate, so that the exudate during the cellular phase changes. It will be it could be bloody if this is a larger bloody wound. It could be purulent if there's infectious material in there. It could start to get cloudy or fibrinous if there's old tissue in there. It kind of depends on the wound itself. That area, or that the neutrophils themselves releasing their enzymes, helps to debride the wound. It helps the lymph system filters some of that debris out to the lymph nodes. And then the macrophages arrive, which is true. So it's monocytes are activated into macrophages. They will start to phagocytize, but they have the ability as well as antigen presenting cells. So they could present an infectious process, a bacterial process especially, to an immature lymphocyte or T helper cell that'll help call in the adaptive response if necessary. So you guys did, that was pretty much what a large part of what the exam and the case studies were. So hopefully all that sounds very familiar. So when we talk about white blood cells, I often like to relate this lecture to you reviewing a complete blood count or a CBC result on a patient. So when we're just talking about white blood cells in general, we are calling those leukocytes, which is just white blood cell. There's obviously many types of white blood cells, but we are referring in particular to leukocytes, which is what the first lab value is on that CBC, which is the WBC count, is the leukocyte count. And the WBC count is telling us the total count of all the types of white blood cells that are available. So we know that the lifespan of white blood cells is short, and so that we're constantly at least making some white blood cells to keep in the blood if needed, sort of as surveillance or as the beginning to help start the process. Conditions that decrease the availability of stem cells or growth factors would decrease the white blood cell production in general, which could be other pathological disorders. So you can have disorder of white blood cell production in terms of the amount, the quantity that's available, if there's too much available, or quality. So one of the leukocyte disorders or white blood cell disorders could be a quantitative disorder in that there is an increase or decrease in the number of white blood cells. Increased counts could be a normal adaptive response to infection because when those different types of white blood cells are being used, they will send messages to the bone marrow to increase production. So I would expect if somebody had an infection, especially that was going along with the tissue injury, that the leukocyte count would increase in response to what the body needs. However, sometimes that response is too high and that might be a cancer. If there is a decreased count, it could be that there's destruction of those cells or a problem with production in the bone marrow. Qualitative disorders mean that the blood cells are being made, but they are poorly functioning, and that's usually a genetic disorder, and we won't get too far into those types of things. So leukocytosis is when our white blood cell count is too high, and it sort of depends on whatever lab that you're going with. But in general, I've seen that the white blood cell count will be between 4,000 to 10,000. And that above that would be considered leukocytosis. It's usually reactive to a microorganism or a stressor, but it could be pathological, such as in the setting of cancer. Leukopenia is when the counts are lower than abnormal. Leukopenia is an abnormal state. There's not an adaptive response to stress that leukopenia would be. It's usually that the person's worn out and they're not able to make the white blood cells they need. Sometimes an ominous sign to an infection that they're actually getting septic and their own body can't make the cells that are needed, or it can be related to medications or other issues. So I'm not sure if you guys have ever heard people talk about white blood cell counts. So we have our white blood cell count, which is our, 4,000 to 10,000. And then especially if it's elevated or decreased, the next step is to look at the differential. Because we want to know of the white blood cells that are present, what percentage of each type of cell is there. Especially looking at neutrophils, our first line, monocytes, our second line, and lymphocytes. So I'm not sure if you've heard the terminology shift to the left or shift to the right, but occasionally that's used to discuss the first stages of infection or trying to figure out the cause of an infection. So we were just talking about the inflammatory process and if there's an infection going on, or once we're starting to use neutrophils and need them beyond the supply that's there, growth factors will be sent to the bone marrow to increase production of immature neutrophils. So here's what, if we look at this, here's what a mature neutrophil looks like, where there's these little dots, which are the granulocytes, and then 3 segments. So sometimes those are referred to as segs. Or
Can I stop you for just a second? Because
Sure.
all I see is a white screen. So I just thought you were talking, but I can't actually see any slides.
Does anyone else
Or
have that issue? Because I'm sharing.
Okay, maybe I'll just restart mine and see what happens.
Yeah, or you might want to log in and out.
Okay, I'll do that.
Okay. Oh yeah, sometimes you just have to restart. I've had that happen before to me, or sometimes I think I'm talking and my microphone isn't working or something. Anyway, so these are mature neutrophils as their little internal components are in segmented pieces. Immature neutrophils are sometimes referred to as what are called bands, because instead of being that perfect, those little segments, instead of being in segments, it'll be a band, the same appearance, but it didn't have time or the maturity to make the segs. So immature ones are sometimes considered banned. So you might have looked at or heard a provider talk about looking at the white blood cell count and it's high, and then they want to see what the percentage of neutrophils is because we know those are the first line white blood cells to any insult. And then they look at this, what is the percentage of bands versus segments? Because if you have a high white blood cell count with more neutrophils and there's evidence of immature neutrophils, that means the body is responding to an acute infection, most likely bacterial in nature. And this gives us, and that is what is called a shift to the left. So when you're looking at a white blood cell count, that besides the patient's story and symptoms, that can give you some information as well. Sometimes you will look at the differential, and over time, especially if you get to take care of this patient for a while, you'll see that this number starts to go down a bit, and the monocytes and lymphocytes start to go up because we know this is the second line cells, and especially in the case of as the infection is been present for a while, or viral infections especially, there'll be an increase in lymphocytes over time. And when these go down and the lymphocytes go up, that's considered a shift to the right. So there's ways to look at the leukocyte count, giving us a general number, and then we look at specific types of leukocytes to try to figure out where we are during an infection or what type of infection we're dealing with, especially in the setting of leukocytosis. Leukopenia, or low white blood cell count, occurs with prolonged severe infection if there's decreased production for some reason, if the white blood cells are poorly made and there's decreased quality, so they're destroyed early, or if for some reason the neutrophils are being sequestered someplace, they're not in active circulation. And one of the places that neutrophils or white blood cells can get sequestered in is the spleen, which we'll go into further. Sometimes we can see when we're looking at the differential that it's the monocytes that have increased. And an increased number of monocytes is monocytosis, as we discussed, seen later in bacterial infections, sometimes noted in a chronic infection or even a myocardial infarction. Monocytopenia, or a decrease in circulating monocytes, is pretty rare and is associated with what's listed there, some prednisone over time and a specific type of leukemia. Lymphocytes, lymphocytosis, if the differential shows that there's an increase in circulating lymphocytes, it could be an acute viral infection, it could be leukemia or a chronic infection. Lymphopenia, or a decrease in lymphocyte counts, is usually related to viral or radiation destruction or other immune deficiencies, such as HIV, because HIV is specifically an infection of T helper lymphocytes, and it destroys the T helper lymphocytes. So then obviously over time, not initially, you're going to start to see a decrease in those counts. So at this point, just as we've talked about the white blood cells, I think I'm going to have us take a little break before we begin mono and the leukemias. So we'll take, it's like 7:45, we'll take a 10-minute break. I will pull up that study guide and put it on Moodle site, on our Moodle site, while we're taking a break. So let's return to class at 7:55. So I'm going to stop recording for a second and get, oops, that is not what I wanted to type. And sharing my screen, and then I will fix our Moodle page. So I'll see you in about 10 minutes. Let me just reshare again. I did, while we were on break, I did add The study guide for exam 3 is on our Moodle page now, and I did, oops. I hate it when I hit the wrong button. I did add, if you go under our topic for July 2nd, you can now see, you don't have to put anything in here where it says mid-semester appointment. This is just sort of a space for my grade book, so I know to give people the points if we have our appointment. But then this is where you can put your rough draft for your cancer presentation, so then I can take a look at it and give you feedback on it. Okay, so we left off about to talk about infectious mononucleosis. And this is a type of viral infection that is specifically infecting B cell lymphocytes. So the agent is transmitted through saliva. So it's personal contact, either, sharing secretions in some way, kissing, hence the name kissing disease, but it could be from, sharing cups or any way that you share saliva or mucosal secretions. So infectious mononucleosis is actually a general term for the way the B lymphocyte looks when it's infected by the virus. If you look at it under the microscope, its nucleus has a specific appearance. There are other causes in terms of viruses of infectious mononucleosis, but by and large, the largest causative agent is Epstein-Barr virus. So this Epstein-Barr virus infects the B cell, incorporating itself into its DNA. So remember, viruses are not simple cellular structures that exist outside of our cells and, damage our cells for sure by releasing exotoxins to take from our cells. But they also, viruses are separate pieces of DNA with the capsule, and they must have surface proteins that attach to the surface of our particular cell that they gain entry into. And in terms of Epstein-Barr virus, that means it would, this is our little viral particle, would attach to our B cell lymphocyte, gain entry, incorporate itself into our DNA in order to make more viral particles. So when this occurs, this B lymphocyte is no longer able to perform the function of a B cell lymphocyte. So it cannot differentiate into a specific antigen clone and then further differentiate into plasma cells if we were confronted with a bacterial infection at the same time. This particular cell won't be able to do that. It has now been basically been rendered to be a Epstein-Barr virus factory. So the way that our body clears itself of a viral infection is through cytotoxic T cells. So instead of with a bacterial infection, a macrophage or a natural killer cell or a dendritic cell being an antigen presenting cell, which would use that MHC2 receptor to place pieces of an antigen on itself to present to a T helper cell, our virally infected cell has to show that it's infected. Does anyone remember that process or what happens? That was the end of the lecture, so sometimes that's the part that gets a little hazy. Right, so the cell itself becomes its own antigen presenting cell, and it is via, correct Karis, it is via a different MHC receptor, so MHC receptor 1, which then would connect to T helper cell and help differentiate and find the correct cytotoxic T cell that would be antigen specific. So that means in this setting, in order to get rid of this viral infection, we need an increase in lymphocyte production, specifically of those cytotoxic T cells. And then that would connect via that MHC1 receptor to this virally infected B lymphocyte and destroy it. That would be how our own immune system would take care of that. There probably will always be daughter cells or some B lymphocytes that have Epstein-Barr virus in them. And that means that Epstein-Barr virus is what is called a cancer initiator. It is possible after this infection that we have remaining B cell lymphocytes that are mutated, that contain this viral information, and over time could then later become a lymphoma, especially Burkitt's lymphoma. So that is possible. It could be that because we know the stages of infection include incubation and prodromal symptoms, it's possible that the person who has this infection could give the patient, a different person, the infection without knowing that they have symptoms. So the clinical course for Epstein-Barr or infectious mononucleosis is a long incubation period. So the person could have been exposed to this infection, but it might not be for 1 to 2 months before they start to feel symptoms. In the prodromal period, or the time when they're first starting to feel symptoms, there might be a couple days of feeling tired, not hungry, and some chills. Then they develop fever, pharyngitis, and lymphadenopathy, particularly posterior cervical lymphadenopathy. So the reason they develop pharyngitis is really because the way that the Epstein-Barr virus gets inside is through the cells in the throat. That's how it gets into the bloodstream, and that's the area that's infected that will drain into the lymph nodes of the neck. Here is something that can be interesting with people who have Epstein-Barr. So they could have either leukopenia or leukocytosis. So leukopenia means they have a low white blood cell count versus leukocytosis with 30% lymphocytes. So they have a viral infection, they can have an increase in white blood cells because we're increasing the production of cytotoxic T cell lymphocytes in particular. So this is the usual scenario, leukocytosis with primarily lymphocytes. It is possible that mutated lymphocytes will be sequestered in the spleen because they're not correct. And they might be stuck in the spleen, which can lead to a leukopenia and splenic enlargement. And so the biggest complication, acute complication of Epstein-Barr virus is splenic rupture. If the spleen is enlarged past the rib cage, then it is prone to injury and would bleed excessively. So that's Epstein-Barr in a nutshell. So here's a question for you related to the primary and secondary immune response. So when we were talking about the adaptive immune system, there will be antibody production as well, the IgM and IgG. We talked about how the primary exposure for a person to an infection would have a delay in lymphocyte production. And then we would see the IgM response followed by the IgG response, and then we get memory. Then subsequent exposures or later on, if we were exposed again to that infection, we would have a IgM response that was a lot faster and an IgG response that was a lot faster and much more efficient with a huge amount of IgG that the patient would probably not even realize that they were re-exposed. So if a person comes to see you and says, I think I've been exposed to mono, I have these symptoms, it's been, over a month since the possible exposure, so could be that they've had time to mount an immune response. One of the ways that you could diagnose Epstein-Barr virus infection is to do what's called an Epstein-Barr viral panel. And you can do this for lots of viruses. You can measure antibody response to viruses. You can measure pieces of the virus. But you could get an Epstein-Barr viral test that would look at the IgM count and the IgG count. If you did this panel and only IgG was positive, but IgM it was negative, what does that mean?
That they've had it before.
Right. This is what is showing you that they have retained immunity. They have been exposed to Epstein-Barr virus, and their body has circulating immunoglobulin in case they would ever be exposed to it again. If they were both positive, then you're dealing with an acute infection, because that's the time that you get IgM. Like when you get your hepatitis B antibody test, they're looking for the presence of IgG to say that you have an immune response ready. So yes, that is correct. Leukemias is the next part. These are cancers of the blood-forming organ, so cancer that takes place in the bone marrow. Is uncontrolled proliferation of immature leukocytes. And so leukemia is different from other cancers in terms of how it's staged and classified. It's classified by the cell of origin, so which cell is dividing and proliferating without the natural barriers to proliferation that we talked about in the first class, that stops cells from over-dividing. And it's on the rate of progression, how fast this is occurring. But it's not like there's one tumor site that we measure this tumor size, and then we see how many lymph nodes are involved, and then we see if it's metastasized anywhere. This is going to be throughout the bloodstream. So there isn't like a solid tumor that we can measure. The problem with this is with this overgrowth of a particular type of white blood cell, those white blood cells aren't capable of doing the job they're supposed to. They're very immature. And they overcrowd the rest of the cells that are produced in the bone marrow, such as red blood cells and platelets. So leukemias are classified as being either acute or chronic. Acute leukemia means that the cells are very undifferentiated, very immature. They're usually blast cells, which I know you didn't memorize this slide, but a blast cell that is way up here. It's a very undifferentiated, immature cell. That's the cell that's overgrowing. Rapid onset with short survival. A chronic, the cell will be more mature. It might be one of the progenitor cells that's overgrowing, and a slower progression. And people usually live longer with chronic anemias. Risks of leukemia include exposures to cancer initiators. So viral infections are cancer initiators. These are several types that could do that: smoking, radiation, other chemical exposures. Pancytopenia will be a symptom of leukemia, meaning there's a reduction in all the other components of the bone marrow. And these are acute lymphocytic leukemia is an acute rapid onset proliferation of immature lymphoid cells, and is generally associated with this type of chromosomal abnormality. This is very common childhood leukemia. And there does tend to be a family tendency for, these are some of the risk factors, where acute myeloid leukemia or myelogenous leukemia is AML is more common in adults, and is the myeloid side. So those other immature white blood cells, the neutrophils, monocytes, it's those progenitor cells that are overgrowing. So again, we will still have similar features because of crowding of the bone marrow. Anemia, potential easy bleeding. The fever could be caused by infection because the person is not able to fight infections that they encounter because they don't have functioning white blood cells. It can also be, sometimes people will get fevers, especially at night, when they don't necessarily have infections, but because this rapid division of these cells also involves release of cytokines and interleukins that can bring their temperature up too. Changes in weight because of the increased proliferation of cells that uses a lot of ATP, a lot of energy. And then these are the chronic leukemias. They're usually diagnosed later in life. They're affecting different, either the myeloid cells or the lymphoid cells. And this is just a slide to kind of sum up the characteristics, progression, and primary cell type of the different leukemias. And then briefly just talk about lymphomas before we move on to anemias. So lymphomas, the actual cancer growth is occurring in lymphoid tissue. And lymphoid tissue involves lymph nodes and wherever they are located throughout the body. The spleen is also part of that. The spleen is located under the rib cage in the left upper quadrant, and has is divided into two types of cells, red pulp and white pulp. The red pulp has tracts where red blood cells that are done, that they're old, get caught into, and they are brought to the macrophages inside the spleen to be broken down and recycled, which we'll talk about when we talk about red blood cells. Blood goes through the spleen, and if there are virally infected cells or that are in the bloodstream, or white blood cells that are old and non-functioning, they can be sequestered in the spleen. There's a lot of T lymphocytes in the spleen, so oftentimes when someone has a viral infection and we need an increase in T cell lymphocytes, the spleen might become enlarged because we are causing increased division of T lymphocytes in order to fight the infection. Lymph nodes are located throughout the body. Those are filters. Remember, our lymph tissue, our lymph vessels drain into lymph nodes, and that there are special cell germ centers where we can increase production of B lymphocytes or T lymphocytes depending on the needs of the body. So to have a growth or an increase in size of a lymph node is essentially lymphadenopathy, where a lymph node, it becomes easy to feel and potentially has pain associated with it. The lymph nodes are located throughout the body. If we looked at that picture, that's just many of the areas that lymph nodes live, in the neck, around the head, the thymus, which is part of our immature immune system when we're growing our T lymphocytes during our first year of life. There's lymph nodes, in the arms, underarm, and the abdomen. Lymph nodes are located in the liver. Appendix has lymphoid tissue. There's lymph tissue inside the intestines. It's everywhere. So they can be locally near an area of infection, as they're taking in the drainage from the inflammatory process, can become enlarged, or if that macrophage has presented infected antigen to T helper cell, that increase in production of lymphocytes can occur in the nearest lymph node. So I think that was one of our case study questions, or that will be a case study question. Why would a lymph node become enlarged in the setting of infection and inflammation? Sometimes there can be generalized lymphadenopathy that could be related to cancer or a viral infection. So if there's lymphadenopathy, we can think about some of the causes, and it could be an immune or inflammatory condition or an infection, or it could be a cancer. Those are the top two worries that we would have. And a lymphoma is a cancer that specifically occurs in the lymphoid system. So it's an overgrowth or proliferation of lymphocytes that live in lymph nodes or lymphoid tissues, such as the spleen, the thymus, or other areas of lymph tissue like in the liver or in the intestines, wherever they might be. There are two major categories of lymphoma: Hodgkin's lymphoma and non-Hodgkin's lymphoma, that sometimes that are likely related to exposure to environmental agents that lead to genetic mutation, chromosomal abnormalities that are inherited, or viral infections like we talked about Epstein-Barr. Hodgkin's lymphoma, if I was going to pick which lymphoma I'd want, I prefer Hodgkin's. It's a little bit easier to treat. It is characterized by Reed-Sternberg cells. If you would take a biopsy of the lymph node that was affected, you would see these particular cells that kind of look like the eyes on Wall-E, if you ever saw that Disney movie. That cell change is derived from malignant B cells. And there is a release of cytokines with the production of these Reed-Sternberg cells, so that is one of the reasons why people with lymphomas will have fevers and night sweats. The clinical manifestation of a lymphoma is that there is overgrowth and proliferation of malignant cells, so the lymph node becomes enlarged. But if it's usually when a lymph node is enlarged from cancer growth as opposed to inflammatory and infectious growth, it's not tender or painful. It's usually an enlarged, painless lymph node that can cause a lot of pressure. That might give some discomfort, but the lymph node itself is not painful. And because of the cytokine release, there can be night sweats and fever. There is high production. Anytime there's overproliferation of cells and an increased demand for ATP, there can be weight loss and fatigue. Whereas non-Hodgkin's lymphoma is not related to the B lymphocytes, it's related to T lymphocytes, it could be related to B lymphocytes, T lymphocytes, or natural killer lymphocytes. That's how it's classified, which clone of lymphocytes is growing excessively. And it is also related to some kind of either genetic issue or some cancer initiator. So this, instead of being again, we have the lymphadenopathy, but instead of being just one area, it can be located all over the body. So that's one of the big differences between Hodgkin's and non-Hodgkin's lymphoma. Hodgkin's lymphoma is a single group of lymph nodes. It might be the underarm, it might be in the chest, it might be in the groin. And it will kind of march down the lymph nodes as the chain of lymph nodes goes. Whereas non-Hodgkin's lymphoma can be in multiple sites. It will be lymph nodes that have, or lymphoid tissue that has abnormal proliferation, and they will be throughout the body, could be above or below the diaphragm. Extranodal involvement means that there is overgrowth of these lymphocytes that has gone up over or overgrown the actual lymph node itself. Sometimes with a non-Hodgkin's lymphoma, you can't even tell if what is now a cancer was actually even a lymph node. There won't be any normal tissue left. The spread is orderly in Hodgkin's, whereas in non-Hodgkin's it can be all over the place. The fever, night sweats, and weight loss are most common in Hodgkin's, but can occur in non-Hodgkin's. Those Reed-Sternberg cells are present, and non-Hodgkin's tends to be less localized. Any questions related to leukemias or lymphomas or the white blood cell stuff that we talked about before we move on and start talking about red blood cells? Okay. So we'll just start on normal red blood cell production and recycling before we take another little break. So here we are at red blood cells. They are by far the largest group of formed blood cells in the blood sample. There's constant production, maturation, release, because it's not like we just need some as surveillance and then we'll grow more if we need them. We always need them. It takes a full week to make a red blood cell, to go from the progenitor cell to the immature reticulocyte. That's the one that's thrown into the general circulation and matures in a day to the erythrocyte. So an erythrocyte, or a mature red blood cell, will live for 3 to 4 months. Over time, inside that erythrocyte, this biconcave disc, are actin and myosin filaments, which are those part of the cytostructure and give the cell's ability to contract, because red blood cells can contract and move into all different places, into small spaces, and if needed. And so over time, the red blood cell will have less actin and myosin filaments and will start to not be able to be as bendy, which is when it usually gets caught up in the spleen to be recycled. We can increase the production of red blood cells during times of growth, so we can release growth hormone, which becomes insulin-like growth factor during infancy and during when we're teenagers, to help increase the amount of red blood cells, because obviously we need the oxygen to grow. Or erythropoietin, which is the colony stimulating factor, can increase production of red blood cells. So what this is showing you, although it's a very strange picture of a kidney, what is usually, except in those bursts or times where we need extra red blood cells because of growth and development, the usual balance that occurs, there's a constant production of red blood cells. If for some reason the kidney senses hypoxia or less oxygen concentration in the blood, the kidney will release a growth factor called erythropoietin. So there's that original stem cell, that pluripotent adult stem cell in the bone marrow that could start all cell lines. It then becomes a lymphoid or myeloid, differentiates into those both sides. So this is on the myeloid side, and then divides again to becoming a committed erythroid progenitor or precursor. This precursor cell or progenitor cell will go through several divisions that increase its specificity or its maturation. And as this precursor cell further differentiates, you'll notice that It starts out with a large nucleus, and then the nucleus gets smaller, and eventually the nucleus is extruded. So during this process, this weak process, the cell that's released into the bone marrow is an immature reticulocyte, which does not have a nucleus anymore. It has storage of electrolytes, it has actin and myosin filaments, and it certainly has a large amount of hemoglobin. But it doesn't have some of those other cell structures and organelles that other cells have. After a day goes by, we get the mature erythrocyte that you can see that is what we think of as a red blood cell. So the major function, random question, I'm giving, yes, erythropoietin is basically synthetic erythropoietin that the kidney releases, and it is a really good way to stimulate the bone marrow to make red blood cells. Is this what the NIRS system measures when identifying oxygen level? I'm sorry, I don't know what an NIRS is unless I just know it by something else. Can you tell me what that stands for? Oh, is this like a baby thing? Oh. Cerebral kidney pulse ox. No, we use them with ECMOs in adults. Oh. So yeah, it must be measuring oxygen concentration. I will have to look more into that. I can't, we have where do you put them? I'm assuming this is different than the regular pulse ox that you put on the finger of the ear, where you're sending ultraviolet light through over the kidney. That is cool. Wow. I am fascinated. It looks, or we use it on the forehead. You know what? So my first blush feeling about this is that we want to know oxygen concentration in key areas of the body. So I will need to look, I'm writing it down because I have not heard of this, but that doesn't mean anything because wonders never cease and what they can decide to specialize in, especially in critical care or whatever. But we want to be sure certain areas are perfused. So if we're losing perfusion to the kidney or the brain, I'm wondering if that's what it is. Look straight through, nerves looks, oh, huh. So we want to be sure that we're actually getting perfusion of key organs is what my guess is, but I would have to get back to you about that. That's really cool. I wonder how much that is. So I guess my question would be, as always, like once you take, I'm sure a lot. My question would be, as always, my question is, especially when you take my physical assessment class, is what information is this giving you that you didn't have with the other technology? So does this influence how much I oxygenate the patient? Does this influence transfusion practices? Is this, like, why is this better? Is it worth it? It has to do with brain bleeds. If you have a brain bleed, your nerves goes down. So maybe it's like specialized care. I'm fascinated. I have to look into it. Oh, so that would make sense to me too. I always overhear conversations I wish I paid more attention to. So I'm wondering if it's specifically looking at shunting. But again, like, what am I going to do about it? Except to know that that's too bad. Fascinating. I will have to get back to you on this bit of information and why it is important for us to know it if we're working, especially with the critical patients, because there's all kinds of things you can do, but they're not necessarily helpful. There's all kinds of things you can measure, that's for sure. Our Queen of the North is typing. Yeah, I can see that. Yeah, get back to us, Stark. Hmm. I'm just a humble med surg, so I don't know what any of this is. Oh, don't downplay it. It's hard work. I'm curious, but I will have to look. I'm a baby med surg nurse. Yeah, so I'm curious. I will look into it myself and see what I can get from it. I have not. I'll have to ask the critical care people that I work with. I work primarily in surgery, and so um, yeah, Dawn. Way to go, Dawn. Well, that's okay. The patients that we have that go to ICU is rare because obviously we're so good that they don't need to go there. So that's not, critical care is not, I used to work in critical care as a nurse, but that technology is so rapid that a lot of the management stuff I keep learning about because it's definitely changed since I was doing it. So anywho, so the red blood cell, their main function is carrying oxygen to the tissues because we know that the tissues need oxygen in order to carry out anaerobic metabolism, or sorry, aerobic metabolism. So we have high yields, high amount of ATP production for all of the things our body needs to do, and production of waste that the body is able to take care of, water and carbon dioxide as opposed to lactic acid. So we definitely need that. So each red blood cell, each molecule of hemoglobin can carry 4 molecules of oxygen. So I want to show this picture because I don't know why this was like a huge, like mind blown thing for me when I went back to school, was that I'd always thought to myself, here's this red blood cell and has like 4 little carrier sites for oxygen, but that is not the case. Each red blood cell has hundreds of hemoglobin molecules in it, and each hemoglobin molecule has 4 heme binding sites that allow for oxygen. So each red blood cell has lots and lots of oxygen in it, potentially. So just so that you're aware of that. So each molecule of hemoglobin has, and that's another picture of a hemoglobin molecule that would be hundreds of them inside a red blood cell. Each hemoglobin molecule has an alpha globulin chain and a beta globulin chain. And it kind of looks like this. There'll be 2 alphas and 2 betas. And each globulin chain has a heme binding site that's made of iron and porphyrin. And this is where oxygen can bind. Other things can bind there too, like carbon dioxide, because we can carry carbon dioxide out that way, nitrogen, hydrogen. So other substances can bind there. But primarily, there is oxygen that's for oxygen, to carry oxygen to our tissues. Just want to be sure. Yes, CPR should focus on perfusion because there is oxygen in our body at the time that we go down. So it's better to move that oxygen around. Okay, so in order to make a red blood cell, there is a lot of nutritional requirements. And so production of red blood cells requires a lot of nutritional requirements because of the structure of the red blood cell. So we need protein because that's how we make hemoglobin. Those alpha and beta globulin chains are protein. We need vitamins, especially the B complex, because they're in charge of DNA synthesis and heme synthesis. And in the beginning, the progenitor cells for erythrocytes have large nuclei that need to divide, and until we get to the last stage when we actually extrude the DNA, we need the building blocks for DNA. We need other vitamins, vitamin C, riboflavin, niacin, or other B vitamins. We need iron, because that's part of the hemoglobin binding site, and copper for mobilization of iron from tissues. So a lot of requirements in order to create a red blood cell. Like I said, its lifespan is between 3 to 4 months. And what happens over time is the blood cell loses some of its ability to move and contract as the actin myosin filaments inside the blood cell age. And so as that older red blood cell starts to move through the sinuses of the little open areas of the red pulp of the spleen, it can't move through as well if it can't contract like it's supposed to. And then it'll get caught up in the spleen and interface with the macrophages that are in the spleen and be broken down into its component parts for recycling. So if we break down the alpha and beta globulins, that's just protein. We can use protein to remake the alpha and beta parts again, or we can use amino acids for all kinds of things. So that part is easy. The heme unit that was made of iron and porphyrin gets further converted into bilirubin. And the bilirubin, the heme unit can become iron, and the other part of it is the bilirubin. So we can get bilirubin out of our body by changing its, as it moves through the liver, it can be changed for transport and to be removed in the urine. So bilirubin is insoluble in plasma and attaches to proteins for transport. So when it isn't ready for excretion, it is considered unconjugated and is traveling through the bloodstream. In the liver, it can be used and changed into bile, and it can be removed from the blood by being conjugated with a particular amino acid so that it can be removed from the urine. So there are ways for us to get rid of excess bilirubin if we don't need it. So here we are, red blood cell is ready for destruction. The older cells are sequestered in the spleen, and we have our iron and amino acids that are recycled. And the porphyrin part especially goes through some enzyme reactions to become bilirubin, and we can either conjugate it. That extra bilirubin can be in our bloodstream, or we can conjugate it and get it ready to be removed in bile and urine. So I'm going to stop here because the next essential part of this is how the body will reuse the iron, because we can reuse the amino acids and we can get rid of the bilirubin. But now, what are we going to do with this iron? And so before we talk about that, it's 8:40. We'll take a break till 8:50.